a lot of our discussion has been about trauma resuscitation and pediatrics as well. But you could put a chest tube in a kid, of course, but we're practicing on an adult model. This is our adult model. I don't have a name for them. We need a name. Anyway, we have a chest tube model for practicing. Oh, that or fluorocentesis, whatever you prefer. So if you're in a trauma setting and somebody has major chest trauma.
Under 30 minutes.
30 minutes, okay. You know, and let's say they're short of breath, hypoxic, hypotensive, because you can lose a lot of blood in the chest. Then you might have to put in a chest tube. But we do, well, actually here at Living Room we have POCUS, so you might be able to actually quickly tell if there's an effusion going on by POCUS, but you might actually just have to put in a chest tube if, you know, crepitance, unstable chest wall, and somebody that you think probably has bled a lot into the chest. So if it was it could be a traumatic pneumothorax as well as a traumatic hemothorax, or it could be a hemopneumothorax, right? Some things that you're going to obviously listen to the lungs to see if there's asymmetry, palpate the chest wall. And then also if the trachea is deviated one side to the other, it could be deviated away if there's too much pressure in here from all the fluid and the air pushing the trachea over. Okay, so in trauma setting, you generally want a relatively large chest tube. This one right here is a 32, which might be something that you would choose, or you could choose like a 28 to 30. We used to put in even bigger ones, but then it was, with some research, decided that going up to like 36 is not necessary to get the fluid out. In the package, sometimes when you buy a chest tube, they have something called a trocar on the inside, okay? I'm showing you this just for a great warning. Don't use it, all right? This can kill somebody, because if you slip and you go too far, you can easily puncture the heart or cause a hole in the lung that wasn't there to begin with. Okay, so some people use these because they are sharp, and here in the so it comes this way. But in my strong opinion is, don't put in a chest tube using the trocar. We are going to show you a different method that is safer. Okay, but I wanted to show you this packaging so that you are aware. So once you decide that you need to put in a chest tube, you're going to have to decide where you're going to put it. Generally, we do mid-axillary line or anterior axillary line, and it's a bit easier on men because you kind of just usually use kind of around the nipple line, but for women, the nipple line might be lower, but about there, like in the 4 to 6 intercostal space. If you go too low, obviously you could hit the liver. It's bad to do a liver biopsy when you're trying to do a chest tube. You know, you go high enough that you're not going to hit the liver or the spleen on the other side. So first of all, what you're going to do is you're going to identify the site, and I prefer to use lots of lidocaine. I use a whole bottle. Like it's not a syringe full. I just use the whole bottle in that whole area. I go down to the top of the rib, and I want to anesthetize the periosteum. I think my patients appreciate it. Okay, you're opening up a bottle, just use the whole thing, but you got to go quick because this is a sick patient. Infiltrate all around. Okay, then once you identify the spot, this is like the anterior axillary line or the axillary line, then you are going to make a cut, about a 2-inch cut, maybe 3 centimeter cut. I prefer to cut, you can identify the ribs. So I think it makes sense to kind of, you are not cutting down to the rib, but you kind of cut along a rib. cut along a rib. That prevents you from actually cutting too deep, right? Okay, you're not going to put the chest tube in through the rib. You're going to put the chest tube in above the rib. Why do we do that?
Because of neurovascular issues.
Exactly. So the nerve and the blood vessels run under the rib. So you do not want to mess with the intercostal arteries, or you could have a bloody mess. So you want to, after you cut like your 3 centimeter, like along the rib, then you have your trocar. We're gonna do all this. You actually poke into the pleura. So you go on the rib, and then you go above. So there's wiggle room. We all have a little bit of fat, and there's wiggle room between the skin and the rib, and then to the intercostal muscles. So then you hold it close, you poke in, you will feel a pop. It feels actually a little bit difficult to get it through there, but you have to get through the pleura, like the pleura. So you hold it close. You do not hold far away, because if you lose control, the whole thing is going to go in, and you could obviously just, you get a little bit of wind. Yeah, I'm going to have to, here, use this thing. Maybe this, or, okay, very good. All right, thank you. So once you're in, then you take your instrument and you spread it, so that you then, and that takes a little bit of force. You spread it, and then it spreads open. Then you put your finger in. And you feel inside, and you know that you're in there because you are touching this soft thing called the lungs. All right. Then you have another instrument that has the chest tube on it. You guide it in to the top. You're going to go up, right? And then you're done with putting the chest tube in. You have to cut the end off, because this end piece will not attach to the fluid collection device. So you have a scissors, you cut that off. We'll go through all this over here. And then you attach it to the suction device. And then you suture it in. Any questions? How many people have put in a chest tube? You put in one? You guys have done some? Just like one or a bunch? You just done some?
How far up do you go?
That's a great question. So you're going to have to kind of say, see, there are some numbers on here. Okay, so one thing that you have to do is see these little holes here? These holes here? All of these have to be in the chest. And some chest tubes actually have a lot more of these holes, all right? So all of the holes have to be in the chest, or it won't work, because when you just get the air from the outside going in and into the, all of the holes have to be in. You would just sort of gestalt, say, I went in down here, I'm probably going to want to go in about 10 or 12. If it's a tall person, you're going to put a little bit more, okay? Kids, you're going to have to kind of say, this is a little kid. Once the all these are in, just go in a little bit more, okay? Because you still have some room to go. So if somebody doesn't want to put in a chest tube and they want to do the bramula, like pleurocentesis, let's just talk about that. Okay, so maybe you're working and somebody has florid congestive heart failure or a malignant effusion. Like we have a lot of cancer patients here. They're short of breath, they're hypoxic, and maybe you get a chest x-ray and you see that they have effusions on both sides, or you do a ultrasound and you see large effusions. So you can take some of the fluid off simply with a bramula, and then you push it in. You can take the thing out and attach it to the tube of a urine collection system, and allow. And this again is you go above the rib, right? And you're going to want to be pretty comfortable with how much effusion there is. I've done these with the POCUS, and you can actually see where the fluid is. You can go right there, like even if it's a small amount, you can get it out because you exactly know where it is with the pocus. Okay. Probably most people here have done that before, right? Have you guys done pleurocentesis?
Yeah.
Like drainage. Do you feel comfortable with that? Okay. Have you done that before? No? Okay. Well, maybe you want to do one of them. Does that sound good? Okay. Okay. So this is our model, which I had, you guys know Jephthah. Everybody's got gloves.
Yes.
Jephthah and his crew, Victor, Jonathan, and some others helped me put this together. Okay. We need a name for this guy. I don't have a name, but
Jackson is good.
Jackson is good. Oops, I lost my phone. Where'd my phone go? Okay, so this is actually go ribs on the side. So you're gonna, so you can feel the ribs. You can feel the ribs, right? Feel the ribs.
Yeah.
Okay. Now, we can have two people do it at once. Who wants to start? You guys want to start? Okay, why don't you guys come up here? Okay, so this is, see, these are size 30, and these would be perfectly adequately large for trauma. One on either side, there you go. Okay, so the instruments that you're going to need is, first of all, you're going to numb it all up. I didn't put that in here, but you are going to numb up the area that you have identified. The largest one of these is the one that you're going to poke. These are about the same. You're going to use to poke through when you put in the chest tube. Remember I said you want to have a lot of control. So when I poke like this. That means my hand is going to prevent it from going too far in. If you hold that out here and you start poking in, once you get through the pleura, you're gonna go like this because there's resistance with the pleura. Then if it goes in too far, you could have really hurt the heart or the lungs. Okay. So let's identify some area. So you're gonna feel the rib, and then you're going to take your scalpel. Here's a scalpel. Okay, be careful with all these. I don't want my goal is to have nobody hurt themselves, right? Okay, careful. Always be careful with scalpels. So you're gonna identify. I think it's smart to when you use the scalpel, you go along the rib. You're not really trying to cut. You are not trying to cut the bone. You just want to have a stop so that you don't go too deep, right? Does that make sense? You have a curious look on your face. Okay, so go ahead and cut here, cut there, something like that, like a 3 centimeter cut. Oh, yeah, so you don't have to count exactly, because the ribs on the goat don't actually count quite as well as, in real humans, you're going to kind of use the nipple line on a man and then sort of the equivalent on a woman, okay? Okay, so you made a cut? Okay, good. Okay, now you made a cut. Now you're going to use this to puncture through. Okay, I'll put the scalpel over here so nobody hurts himself. I go like this, you go like this. Okay, so you've made the cut here. You were going to want to go, okay, you cut here, so I would go above this one, all right? So your fingers are close to the instrument, and you're going to puncture in. Okay, like that. It is a puncture through. But see, you had your fingers there, you prevented from trauma. Now you're going to open this up. Going to open up and spread. Open up and spread to get a hole big enough. You're going to try to spread the intercostal muscles. You see how we're doing over here. Okay. And when you puncture, did you puncture in already? No. Oh, okay. Okay. So hold down here. Hold close so that if you slip, you won't puncture farther than you want to go. and you're going to go above the rib, right? And it's actually kind of a pop, right? Yeah. Okay. Now you're going to open this up. Go ahead. Like, it takes a little bit of muscle to spread the intercostal muscles. Okay. Now, once you have that there, you put. Okay. First of all, let's load a chest tube with another one of these. This is what you do. You're gonna load it, ready to put in. Okay, we're gonna put this up here. I'm gonna load yours like this. But so don't keep that in there. Keep that in there. Because the problem is sometimes you lose your space and then that's not good. Okay, now you use your right finger and you put it in there. So take this out and put your finger in. Wait, you wanted to go a little quicker, but okay. So you want your finger in there so that you can feel that there is lung, that you know where you're at. You don't want to feel liver. You don't want to feel spleen. You want to feel a soft, mushy lung, right? Okay, do you feel you can take this out now.
My finger is too big.
Okay, well, then you would have to make a little bigger hole, but that's okay. Okay, can you feel something soft inside?
Yeah.
Okay, there is something soft inside. Okay, then now you use this and you guide it in and you go to the head. Okay? What do you need to do? Oh yeah, you can put a clamp on that end. Good point. I failed to mention that because you might have a bunch of blood flushing out, right? You've been there. You know, right? So you want to actually guide this along your finger. You're going to have to make the hole big enough so your finger can fit in. Okay, you can so we did it. Okay, so like if I was like this, then I would like put this in and then sort of take this out at the same time putting it in. Okay, and the other thing I failed to mention is that if it's a hemothorax, you're going to have a clamp end. If it's a pneumothorax, you're just going to get air. Okay, so now you're going to take that one out. You're going to have to unclamp that. Oops. Yeah, there you go. And then slowly guide this up. Okay. Now you have your chest tube in. We will suture it in. But okay, so now you can attach it to your drainage system. All right? This is the drainage system. Okay, this often happens. You have something on here that doesn't fit to this. So what you're going to do is you're just going to cut the end off. You cut this end off. Cut that end off, and you attach it. Should work. Doesn't, that's a problem. I hope. Yeah. Right. Okay. All right. Now, the suturing. I think I'm gonna sort of demonstrate. Yeah. Can you grab me a suture? Did you get it in?
Yeah.
Okay. Guide it in for a ways.
Until almost, you said 13, 12.
Yeah, that's fine. I mean, you're going to kind of say, like, this is a big person or a little person. Okay. So there's no right way to suture these in, but rest assured, no matter what you do, the surgeon will say you did it wrong. That's the rule. There is no right way to do it. But every surgeon has their way to do it, and if you don't do it, they'll always tell you did it wrong. Those are the rules. As long as it doesn't get so that you basically take some over here, take some on the top, some on the bottom. You can use your pickups. You have pickups in the tray.
Yes.
Use another sharpest.
Faucet.
Okay. You could put a suture on the other side as well. There. Go on the other side. I'm taking this away from you, but do another one on the other side.
Faucet.
Yeah, do on the other side. and then you're going to find your friendly neighborhood nurse to help you with a nice dressing on there. Zero form, like something that's Vaseline impregnated, is a good idea. Basically, okay, so this is a little tougher than skin. This is goat. Sorry.
Sorry.
Okay, anyway, so basically put something on this side, something on the other side, tie it around here to secure it, and then you're done. Then you put a dressing on it, okay? So I think we're going to stop here just so that we can have somebody else do it. Is that okay?
Yes.
Okay, okay. So if you want to, it's a little bit tough to get this through here. You can try if you want, but I just want other people to get an experience of the chest tube. All right, so let's put the scalpel over here just so we're always safe. There's a scalpel in here. Be careful, everybody. Okay, who wants to go next? Okay, Godfrey, here we go. So just pick another rib, kind of another place. That I kind of stole your thunder with the suturing. Like, are you okay with that? I sort of took it away. Sorry, I just wanted to demonstrate. Okay, I just want everybody to have a chance.
There was no lidocaine.
There was no lidocaine, yeah. But really use lidocaine. Really, like, just infiltrate that whole area. Put a lot of lidocaine and down to the periosteum of your patients will appreciate it, right? Because it hurts, you know.
Which one do you prefer? The one with adrenaline or without?
I usually use the one without, but it doesn't matter. Either one's fine for this kind of procedure. It doesn't really matter. You know, I would get whatever. What was that? 10 more minutes. So we're gonna have to put some chest tubes in quickly here. Okay. Thanks. Thank you, Josh. Okay.
And the thin lump.
So you kind of cut along the rib, just so you have that. So now this is okay. So this is where you hold it close, and you're going to go like this. So you don't want to have too much leeway, because then you could accidentally puncture something. Yes, go up. There you go. Yeah. See, so it's like hard to do, and it's hard in humans too, right? Be careful.
So on the suture.
Yeah, and that's actually also hard too, to split the intercostal muscles. In fact, it might be even harder in humans because they don't have that much intercostal muscles in the goat. Yeah. Put your finger in. Okay, I'm gonna load your chest tube. Okay. Yeah, good. Thanks. Okay, and then you're gonna kind of guide along your finger as you go, and then head towards the head, right? Okay. Do you want to go next? Yeah. Okay. Okay. So I'm not really going to let everybody suture, just so that everybody have a chance to cut. Okay. I think probably most people here are pretty good with suturing. You get the concept? Yeah. Okay. Okay. I mean, it's cool to do all of it, but we just want everybody to have a chance. All right. So, scalpel. Where does scalpel go? Careful with these scalpels. Please don't hurt yourself. I will feel guilty. I don't want to feel guilty. What's his name? Jackson?
Jackson.
Why are we calling him Jackson? Who's Jackson?
Oh no.
He's a Chelsea fan.
He's a Chelsea fan. So.
He's one of the what?
I'm a Chelsea fan. Some soccer team in Britain.
Okay.
Yeah, so there's a guy called Jackson.
Soccer guy?
Yeah.
Okay. So you cut along the rib?
took a man that
You cut along the rib? Okay. And you infiltrated it. Okay. So let me load this for you. Okay. And then you're going to... It actually is kind of hard to split the intercostal.
Very important.
Good. Put your finger in.
First time I attended this
Are you
thing,
left-handed or
it was
right?
so hard to go.
Left-handed? So you might want to put, you're left-handed? Oh, so you probably want to put your left hand in there, then you can use your right hand to guide the chest tube in. Right? Okay. And then once it's like clearly in, you can pull your instrument out and then just guide it in. Oh, and one more thing we want, if it was bloody, you would want to
Helps,
implant.
yeah. But with,
Okay?
Yes.
Who has not done it yet? Monica, when
but
you
with
come over
such
here.
training,
Okay. So,
but with such training,
yeah,
they
you
bring
can
some
definitely
sort
go
of some
back there
courage.
somewhere. All right, we need scalpel. You're going to make an
needs to
incision
show us that
along
one.
the rib. Just be careful, just don't hurt yourself. That's all I ask, right? I just don't want anybody to have to go to OPD procedures, right? What happened to you? I was dealing with a goat.
So
Okay.
uh,
So you have like about a 3 centimeter. Yes. Okay. Excellent. So now you're gonna hold it like right distal. Okay. So I want you to hold even closer, just so you have more protection.
I got him.
Okay. Did it pump?
Yeah.
You felt the pop,
Yes.
right? So the pop is actually kind of the same as what it feels like in a human. It's really a pop, right? Okay, so then you do spread it. Did you spread the muscles?
I did.
Okay, very good. And you got your finger in there. Put that up there. Okay, and then we would have like if it was a pneumothorax, we'd go like this, right? Yes, excellent. Did you feel the soft lung on the inside? Lungish thing. It's a pillow. Yeah. Put it in, and then suture. Okay, is everybody put in a chest tube?
Yes.
Okay, good. Here, you want to practice suturing? You can if you want. It's just a little bit hard. It's hard. The skin is not easy to suit to. So here's just don't hurt. Just don't poke yourself. That's all I ask. Oh, pardon? You're not going to poke yourself, or you don't want to do it? Okay. Okay. Any questions? Yeah.
question:
Yes.
if you place and unfortunately it gets out,
Oh, comes out.
do you go ahead and place it again, or what do you do?
Yeah, if you hadn't solved the problem,
Okay.
like say there was ongoing bleeding on the inside, then you need to put another one in, right?
Same position, or you change the position?
Oh, I would like do a little bit higher, not the same hole. I wouldn't do
Okay.
the same hole. I'd probably just sew this one up and go with a different hole, like the next rib up.
Okay.
Okay. Hopefully that won't happen. So ideally, like a really good dressing after you sutured it in would be like some. I don't think you guys have Zero Form, but something with like Vaseline on it, or ointment, and you wrap it around, and then you have it lie down here with a lot of tape, so that even if somebody accidentally pulls it, it doesn't come out. And if you've sutured it well, hopefully that would also prevent it from getting pulled out.
Sorry.
Yeah.
Another question about use of the pranula.
Yes.
I don't know if you can demonstrate for us.
Yeah. Okay.
Because that is-
So let's
okay.
say you have. Okay, so you have somebody who like malignant effusion, or like horrific congestive heart failure. This is not going to drain a lot of blood, right? This is just for or it could be an empyema or something. Although empyema might end up needing something bigger than this, because empyema is pus and it's thicker, right? So basically, I would ultrasound and find where the fluid is, or if there's a ton of fluid that you saw on chest X-ray. Okay, I would prefer to have the patient sitting up, right? They're sitting up because then all the fluid goes down, right? And so you want to get into the place where all the fluid is. So you basically just have a bramula, and you find you figure out where you're going to go in, and you just put it in. Like go above a rib, just poke in. Okay, this is tougher than real human, but okay. Okay, so you're in, and you can presume that you're in fluid. You'll see if you get fluid here. It's pretty easy. You just kind of take it out and attach it to, like a urine collection. You know how they have the urine collection things with a little tube? And I personally do not walk away with somebody like this. Like, I wouldn't just say, tell the nurse to call me in a half an hour. No, I don't do that because the patient might wiggle. You don't want them to wiggle and have it pulled out. I just want to be there while it's in there. I mean, it's fine that the nurse is hanging out with you, but I don't think it's fair to just walk away and tell the nurse to let me know when it's all done, right? So, I mean, even if I've got the POCUS, I can kind of see how the fluid is going down. And I can also kind of tell when it might have taken out enough. Okay. Sometimes they cough when you do this. Like you put it in, they're taking out the fluid. It's a little bit irritating to the pleura, so they might have a dry cough. Don't worry about it. I mean, like just tell them that, okay, we know this is a reaction to having something poking your pleura. Just be calm, let them cough a little bit. They don't cough a lot, but and then you just pull it out. It's no big deal. Just pull it out, put a Band-Aid on. Okay? Is that easy? Yeah. Okay. Any other questions? Thank you for asking that question.
So you pull it out after
you've gotten as much
established that you've removed everything from inside.
as much as you think you're going to get out for that one poke, right? I mean, like, didn't we take out like 3 liters from that one guy? On one of the man in the male ward, we took out 3 liters from him. He's terrible congestive heart failure, and then he still collected some more. I took out 2 liters later. He had like the whole side was white out. It was like impressive. So yeah, it really helped him breathe.
Does it like since the diameter of the nini is very small, so it takes a lot of time for you to get the fluid out?
It doesn't gush out.
Okay.
It does not gush out, but it's okay. You don't want. I mean, there's other devices, of course, like
The biopsy?
like there's like little pigtail catheters and stuff like this, which I'm not sure how much. Like this is like a little pigtail catheter that you would leave in. So you load it onto the needle. And then you poke it in, and then you guide it in, and then this you would suture. And just put this attach this, and it would just kind of stay for some days until the rest came out. I don't know if you've seen these in patients. Like, have you ever had a patient with a pigtail in? They call it a pigtail because it's got this curvy thing.
Yeah.
I guess pigs have curvy tails. Right? So that's just what this is. But this, you're going to obviously be super careful. You're just going to go in like this. If you're not careful and you keep poking, you're going to do something bad, right? So you have to be very controlled with this long thing. And so that this thing loads onto here before you you numb it up, and then basically poke, and then thread this in over your poke, and then you move out that needle and you attach this to this, and this can be attached to like your suction thing. Okay, this is a device that we use at living room. You may also use this type of thing to collect the fluid. You can attach this to suction if you want. I think we need to get to go into the next section. Okay? All right, so I'll let you go.
Last question before you go.
Wait, sorry.
When you train and at a single moment, how much do you recommend?
When you train at a single moment?
When you train.
Yes.
With the pleurocentesis?
Yes.
As much as you want.
It's
not like the peritoneal fluid that you have to be. You can take it all out.
Okay.
Yeah, as much as you can get out. Yeah, that's a good question. Thank you for asking that.
Okay, thank you.
All right.